everyone, and welcome to our third annual webinar to celebrate National Breastfeeding Week. My name is Denise McGuinness, for those of you who don't know me, and I'm a lecturer in midwifery, assistant professor at the School of Nursing, Midwifery and Health Systems in UCD. My colleague, Dr. Gillian, is an assistant professor in public health and health promotion at the School of Nursing, Psychotherapy and Community Health at Dublin City University. Justin is our learning technologist and will keep us all online today. Thank you, Justin. Our aim today is to enhance your knowledge and skills as you promote, protect and support breastfeeding mothers. Thank you for all you do to support breastfeeding mothers and enjoy the webinar today. Our first speaker is Kelly Kinsella. Kelly, we're delighted to welcome you from the UK. Kelly is the infant feeding lead with the West Hertfordshire Teaching Hospitals. Kelly is a registered midwife and she has a master's in advanced practice. And today, Kelly will be speaking about supporting exclusive breastfeeding following birth. Thank you very much, Kelly, and you're very welcome to the webinar.
Well, lovely introduction. Thank you, Denise. Lovely to be here. Thank you for inviting me. It's a wonderful opportunity. I haven't got very long, and I'm going to kick off really, and I'm hoping that today will inspire you. I don't think I'm going to teach you anything you don't know, but who knows? It's all about inspiration and celebration. So let's go. So just check that my slides are working. Okay, so I'm going to start with what frames our practice here in the UK, and obviously that involves the Baby Friendly Initiative standards. Obviously with the Baby Friendly Initiative standards, we have to go through a staged approach, and we end up having assessments in order to reach accreditation. And the programme supports maternity, not just maternity, but also neonatal care, health visiting, which is public health, children's centres, and we're now developing new standards around paediatrics, which is fantastic. Universities also, you know, when we think about pre-registration, students have competencies in infant feeding, which means that newly qualified midwives will have the training and will be effective skilled practitioners before they even come into health organisations, which is wonderful. I particularly love this centered approach around close and loving relationships within the program. I'm very passionate about parents as partners in care, and obviously breastfeeding is the ultimate goal. But the Baby Friendly Initiative do overall support the best outcome for all babies. It's an evidence-based program, and it's fundamental in terms of where we're going in the UK. The government has taken this on board, and with that, they want every hospital in the UK to be baby friendly by 2023, which is phenomenal, really, considering when we have 93% of maternity units either baby friendly or working towards it, with 90% in public health. So it's a wonderful start to an introduction to parenting, and a great program within itself. I'm going to actually start with some pictures. I think the best place to start really is here we are at birth with this mother and baby. And obviously, if you look at a picture can tell 1,000 stories. You know, her face screams contentment, and she's holding her baby, containing her baby. Obviously, through skin to skin is nakedness of the mother and the baby. But here, for the purposes of this picture, this signals normality. One of the things that obviously what is a requirement is that skin to skin should be immediate, continuous and uninterrupted. I call it from the uterus into ICU. Obviously in normality, that is a key area in terms of being able to develop that sensitive time of a mother and baby to be together and to get to sort of attach and develop and bond. It is something that needs to be prolonged and lengthy. And there's lots of studies that say, yes, we have a minimum requirement of 1 hour, but actually the longer, the better. obviously there's a new standards that are coming out for low risk babies. We don't need to put hats on babies' heads because mothers kiss the babies' heads and there's a contact and attachment going on. It's slightly different for high risk babies. But again, it can start in theatre, and think of the wonderful physiological, biological adaptation that is occurring from birth, particularly for the baby around counter-regulation and preventing complications like hyperglycemia and hypothermia. But if you look at this is a wonderful start to life. There is a lived-in experience for the baby, and for the mother. The mother feels important. Obviously, most cases, breastfeeding occurs naturally after a lengthy period of skin to skin contact. It's the perfect place. Babies get supported with breathing, it regulates the sleep wake brain growth. The list is endless in terms of what it actually does for both this breastfeeding dyad. Mums feel like real mothers for the first time. There is an attachment process. There are so many psychological benefits, and it also increases self-confidence. And there's less likely to be depression or mental health complications. So again, it's a wonderful experience. I actually believe and know that this can be life-changing. My brother recently, or says this quite often, that he has a close attachment to one of his daughters. And it simply is related to when the midwife said 15 years ago, Mark, take your top off and put your baby in skin to skin. And he remembers that 15 years later. And it is an imprinting, and it is life-changing. So as you can see, it's quite a passionate subject for me. We do achieve the first feed in prone, and that's a key area as well. So why do you think babies need the time? As I said, 1 hour is a minimum requirement, but the longer the better. Obviously, this is the Winstrom's 9 stages. They're best known for the behavioural phases. From babies when they're born, from birth to self-attachment to sleeping. And really what this does is it's looking at early self-regulation, optimal self-regulation. So, where the baby is adapting, and what Baby Friendly have done here is they've given the baby a voice in order for us to help to understand why, yes, it's a timeline, but equally why it's a sensitive period, and it's important that we facilitate it and protect it. You can see that obviously the baby is not quite ready for about 2 to 4 minutes because of the stress of being born. But equally, if you look at the rest period, there is lots of frequent moments of rest, which sometimes give off a signal that the baby might be asleep and there's a temptation to perhaps remove the baby. But actually what we want to try and do is wait, we're not ready, things are still going. If you think about crawling, a baby is actually crawling on its mother's abdomen, and that again, a baby moving around, it's touching the uterus and creating oxytocin. And then the wonderful familiarization stage, which can last anything up to an hour, where a baby it's a very important stage where baby's obviously attaching just before self-attachment. There is a temptation in the familiarization stage to help the baby on the breast, but actually the evidence says leave, hands off, allow this baby to work it out. This is really important for consolidation because you can see that babies are storing memories. Not just to cuddle. I love this slide because it's one of my favorite positions, really, in my opinion, the laid back position, which really is the most successful for self-attachment. If the baby is facing prone in a laid back position, it will self-attach, as opposed to a mother holding a baby in her arms down below. So this is a really key area. And it's a big difference in putting a baby to the breast and actually showing a mother what a baby can actually do in terms of moving around. Recently, I had one dad who actually saw his infant crawl to the breast and say, oh my goodness, I feel like I'm in a David Attenborough television show, because this is so natural. It was mind-boggling. And actually, for me, I see it all the time. It still moves me when I see it happen. But it's wonderful to see the changes on the parents because it gives them all that self-confidence. This is obviously weighing. When we think about self-regulation and the baby's ability to attach, and if you look, I mean, here we have two babies. They're born in theatre. It's a vastly clinical environment, and we're using our knowledge and our skills here to try and de-stress the baby by not enhancing more stress hormones. So by weighing in prone, it actually supports the baby's ability to self-regulate and stops the startling reflex. You can see these babies, if you look at them, two very different babies, very calm, very relaxed. You can actually remove a baby from the chest into prone and then put a baby back on the chest. These babies obviously have had a period of being separated from the mother, obviously from surgery for time. It's not immediate. There's a minute of delayed cord clamping. There's then some checks. There's a little bit of weighing. So what we're trying to do is sensitize that area so that when they go to the chest, they're ready and they're already looking to adapt. And you're really keeping those, adrenaline, cortisone levels low, and it's key. Most cases, these babies will attach quickly once they return back to skin. The other thing that I would also encourage here, we have a respiratory distress pathway that we implement within the hour of a baby being born. You do get a lot of babies born by cesarean section with respiratory distress, and it can be mild or severe. And we're looking to keep more separation around respiratory distress babies that do show mild recession or mild nasal flaring or difficulty with breathing, and keeping them with their mothers is actually a key area. And you can see we're keeping the baby on the breast, and it's self-regulating, and you can see its oxygen saturations are normalizing, and all is looking really good. In the past, perhaps this baby would have had a period of being separated from its mother. So really a better outcome, and I would encourage and advocate all checks to be done in skin to skin. Here we have another clinical picture again. This is looking at the anaesthetist space. If you think about it, it's a cesarean section. What is interesting here is there's a whole team effort going on, good communication. You can see the cardiac pads are on the shoulder and not in the baby's space. Her arm is released out from a gown and she's got the cuff on so that it's very easy to get the baby in. This baby is in prone at a 45-degree angle, and this mother and baby are in a surge oxytocin bubble. It's wonderful to see the interaction, the natural instinctive behavior that is already happening. And this is a key part of what we do. Even if you look here, everyone's wrapping up, tidying up. It's a very noisy environment. It's bright. But this mother and baby are interacting with each other, which is an incredible process and a great opportunity to develop that social bonding, social development, mental brain, so on and so forth. I've titled this Going the Extra Mile because, again, if you look closely, this is another baby in skin to skin, and you can see that it's having some respiratory distress support, vapotherm. That's its resus in the background, and this is actually on the neonatal unit. And this is a really, this has taken quite a bit of a team effort because this mother is actually in her bed, just following surgery, unable to walk to the unit. The NICU is far away from the labour ward or can be up another floor. But what we've done is we've taken this mother to her child and we've pushed everything out of the way. You can see the resus in the background. It's a tiny room. There's hardly any space in there for beds. And you can see that we are going the extra mile. And this is a key area in terms of ensuring that mothers and babies should have a protected period of skin to skin contact as much as possible. Obviously, what's really great about this is Renee Flacking, she's a Swedish professor, talks about the environmental signals that we give to parents. And you know, if you walk into a special care baby unit and it's a room full of incubators and there are no beds, that tells you can't stay for very long, or that you get the impression that maybe you can stay for a little while. Whereas if you walked into a special care baby unit and there was perhaps beds there, that would actually tell you that you could stay a long time and be with your baby. And that's a massive impact in terms of what signals we're trying to get across and change in terms of improving care. As Renee would say, skin to skin is a location, it's geography. The care that you give a baby, whether it's in an incubator or on the chest, is exactly the same. And I think that's profound in terms of where we're going. So just really, again, I'm sure you're familiar, we can't mention exclusive breastfeeding without really just going through the core skills that are required to support lactation. And that's enabling mothers to be able to do that. It will require an assessment, an observation, talk someone through what attachment looks like, or what positioning hold is important. To support that with hand expressing is key. These are our basic midwifery, public care, public health, lactation support skills that every woman and baby breastfeeding diet should have in terms of effective support. Mothers need to know and help mothers understand about feeding cues, responsive feeding, and that breastfeeding is a means of comfort and caring for your newborn's needs. Again, this is a lovely feed in terms of, you know, how a baby attaches to the breast and follows a specific process. And part of our core skills are to ensure that we walk a woman through that process. Some women don't need that walk, some women do, but it's really important that we're vigilant, that we can actually assess clinically good milk transfer, and that we anticipate any barriers or complications that may develop and help that woman, that breastfeeding diet, overcome any problems. I'm not sure if you're familiar with the breastfeeding assessment tool. You may be. I wanted to show you this because, again, this is part of our documentation, and I've given a sample of what we currently use. It's a 5-day feeding assessment, and this is a sort of an opportunity to show this to a mother, to give her some insight into what to expect over the next few days, from birth to 5 days, which is a standard process. Obviously, the first 24 hours, babies will feed as a minimum between 3 and 4 times. Some will feed more, the more the merrier. This is a minimum requirement, and it's very, very useful to talk through this tool with mothers because information is power. A lot of women think my baby isn't feeding enough. 9 times out of 10 women give up breastfeeding before they want to, and it's all around communication and information sharing, which is really making the difference. I like to walk women through this tool. I think it's really useful, easy to understand. I actually take a little bit more of a deep dive into the number of feeds within that timeline, whether it's 1 day, 5 day. It's important for me to know the frequency of feeding. Is it enough? No long gaps. I say no hormonal gaps because that's key to set it all up. Obviously, I take more of a deep dive into the nappies, what's going on, what that looks like, getting the mother to understand what she can look for to help herself, and also have a bit more details about, yes, feeding is going well, you're doing better than you think, more about empowering, and also not forgetting the breasts, and checking that the breasts feel normal and that a mother can identify with any problems, or understand that the latch should be comfortable and what to do, what not. This is a great tool, and I thought it would be quite useful to show it to you. Just to wrap up again here, helping the mother learn, I think these are quite, self-explanatory, but I would say that explaining the why is very important for understanding. There are lots and lots of questions, and why taps in directly to managing expectations. Why is my baby crying? Why can't I console my baby? There's a very reasonable explanation. It's all normal, it's all good. Is it okay if I can explain? I can't emphasize that enough. I'll talk a little bit more about effective communication skills. But I wanted to just show you as well that we're all challenged around the supplementing. Obviously, women do supplement, they mix feed, and I think it's very important that we understand why that is the case, and how we can help women overcome these barriers. We here in the UK have a tight regulation on our supplementating rates. Anything over 20% in a day indicates that our standards aren't being implemented, and we have to monitor that on a regular basis. So if I go upstairs now and I do an audit and I find that the results are 65%, 13 women are breastfeeding and 7 are supplementing, there must be something going on. Let's have a look at what the process is. How can we overcome that? Let's have a conversation. Let's put an action plan in place. This is a way of protecting breastfeeding. There is a process going on that we need to identify in order to ensure that mothers get the information, because when they do get the information, they actually do better. So supplementating is challenging. We know the top-up trap, obviously. Obviously mothers go through a process of thinking, I don't have enough milk. We know society doesn't set it up for optimum support. There is a lack of trust in their bodies, and there's a lot going on. Consequently, they reach for formula. Consequently, the baby doesn't come to the breast, and the body responds by not producing enough milk. And round and round we go until we feel that we have failed. And this is where sensitive communication is key. This is the crutch of what we do, really, overcoming the barriers. I would say if this situation arises at any time, listen. The first thing that I would do is listen, and show that you're listening. It's really important to develop your communication skills, because you don't know what's going to be said and what it feels like to be on the receiving end of individuals, and what is going on for them in terms of what point they are at and what that means for them in the long-term goal. Show that you're listening, respond with reflection, repeat what's being said. Communication is key. It can actually make the difference when the dust settles and a mother goes home and is with her infant and actually has heard something in that conversation that gives her the ability to not lose heart, to not lose confidence, to try again. So it might be important to say, it sounds like, it seems like, or you're feeling, which is validation, and that's key. I would also say that obviously, as part of that conversation, is to revisit the goals. Remember what you set out to do. Remind the woman of what it is that she wants to achieve. It's not all lost. Find out what's already known and build on that. Avoid why. I think asking why did you give formula is insensitive. This is a sensitive conversation. It's not empathetic, and it can be accusatory. So ask permission to give the information. I find that when I say, can I tell you about that? The door is wide open. The brain opens up. The woman is waiting to receive the information, and it sticks. Provide information as opposed to giving advice. And I would always feed back, find out what was helpful and what would the plan be going forward. Just to finish, I think we're on time. I've thrown in a couple of books. I can't even begin to say what I've read, but and what is out there. And there is so much out there, but these are the sort of books that I feel have made a difference in terms of my own practice. Even in 12 years of doing this role, I'm still learning. I'm still learning and I'm still evolving. I really think Thomas Hall's Medications and Mother book is a brilliant directory. It's great for quick referencing. I've really enjoyed The Politics of Breastfeeding, but I would also recommend Breastfeeding, Grief and Trauma by Amy Brown. Mixed Up, I haven't read it, I must confess. The volunteers rave about that one. I think looking at the reviews, it's quite good. It's coming from the perspective of women and great empathetic. You've got your baby friendly websites, your breastfeeding network, very good. And then you've got the First Steps Nutrition Trust that monitor all formula in the UK. That's an evidence-based website, really informative. And I just wanted to wrap up on Bump to Breastfeeding. That's a 1 minute. I don't know if anyone's ever used that, but it's a great tool to put on your phone and show the graphics of a baby coming to the breast. If you've got someone that doesn't speak English, or has not English as a first language, it's a great visual to actually get them to understand. I hope that's been useful. I hope I'm on time, and thank you for listening.